Luca Massimi, who will tell us about indications and rationale of filum lysis in pediatric patients.
Buon pomeriggio a tutti, grazie al dottor.
Good afternoon. Thank you very much, Dr. Solerum, and especially Laura Valentini, whom I congratulate as well for the excellent organization. I'm going to introduce a controversial theme, which is a section of the phylum Terminale in children with the indications and rationale. And authors or the next speakers will, in fact, give their reasons. That the Besta University and the New York Chiari Institute will also participate in the debate. This just recalls that the region that we're talking of was already studied by Leonardo, who was very active here in Milan 500 years ago. Leonardo had understood the role of the passage of information from the cord to the brain, and then he thought that the information that went to the soul. He didn't realize that really what we were dealing with is the phylum terminalum. And considering the fact that the phylum, because it's viscoelastic, is there to help dampen the movements of the spine, and everything that makes the phylum non-elastic, be it adipose infiltration or anomalies of any kind, means that you have traction and tension, pulling effects, which in animal models show causes a sort of ischemic damage of a transitory nature. Sometimes, in fact, it is quite specific, and therefore there is a specific mechanism and a pathology which develops. So we have this tethered cord syndrome, which sums it up. There is already one controversy which we can talk about, that is of including just patients who are symptomatic with a tethered cord with a congenital anomaly, or to have and accept preventive treatment for patients who have a tethered cord which shows up radiologically but not symptomatically. From a clinical point of view, we have mentioned these things, so I'm going to skip this. You can see it on the slide. You can see that we have cutaneous signs, bone and joint problems. There's scoliosis, there's pain. This also recalls that where possible, neurological deficits, especially neurological deficits and problems, should be supported by investigations, urodynamic tests especially. Also, indications from radiological investigations, the cord, the conus, which is usually L1, L2, should be looked into, and also, especially in children, there is a certain degree, very often, of normal evidence between T12 L3, and however, when there is the upward movement, in fact, is something which is still a controversial factor. Some people say before birth, some people say 3 months afterwards, as well as the tethered cord and the phylum terminalis. We have to look for other radiological signs over and above, or things that are indicative of other symptoms as well. We've seen scoliosis, for example, the hemivertebrae, and so on, which might be amiss. These are the congenital abnormalities which are associated with tethered cord and which are less controversial than the things that I'm going to talk about. For example, these are all disorders which are seen right in embryonal phase, for example, as you can see here, and including the neural tube closure, which takes place in the so-called primary neurulation. We have therefore primary tethering, which gives rise to the risk of secondary tethering, and then there is the whole question of dermis sinus with or without dermoid cysts, diastemal problems, and then more frequently the presence of lipomyelomyelingocele, which is a broad term, but we know that there are various things included there. Below S2, we're talking about secondary neurulation, which is what we're interested in. This leads to the formation of the filum terminale and a retrogressive anomaly, and it causes this sort of degradation of the spine and the conus that tends to curl up. In secondary neurulation, we have terminal neurocystocele, and then we also the tight, fatty or thick filum, which is a main indication for section of the filum. Here we have some anthropometric data indicated by Pinto. It's one of the main authors that have measured the diameter of the filum with a view to identifying a diameter which would be standard and from which to consider a filum normal or not. Section of the filum gives good outcomes. You can see the variability of the range depends on the different case material. Pain improves even in late surgery, but the neurological deficits also can be stabilized. Mortality is very low. The amount of complications is very similar to CSF fistula, as you can see on the slide. Now, the more controversial aspects, the type of patient that we indicated as candidates, patients with symptoms which in fact are due to tethered cord, but where the conus is in normal position. This is controversial, and here this article refers to this, and it talks about a test administered to many neurosurgeons who came to the pediatric meeting in 2004. This case of acute tethered cord was discussed, and on the right you can see that before the discussion of the clinical case and also after the discussion, most of the neurosurgeons were in fact uncertain or not in agreement with regard to both the diagnosis and also how to deal with it, as to whether to resect the filum or not. Now, what's the underlying pathogenetic hypothesis for dealing with a filum which is apparently normal? The possible resolution of radiology today is not sufficient to show histological anomalies. And for example, here, if you have a normal filum, and here, of course, there are fibrous nerve aspects here, and which is practically normal. We have an abnormal one, and then a really abnormal one on the right, and we have a filum which has a certain degree of abnormality, which this is not seen, however, at MRI, but which makes the filum non-elastic, and therefore patient selection is the key. But what we don't have is the radiological evidence to be able to enroll the patients for surgery. Some authors have proposed using Cini resonance to see the degree of movement, but we don't have normalcy data against which to compare this and say what's normal, what's not. And therefore, some people say that filum which is shifted posteriorly should be considered abnormal. Perhaps high field resonance, magnetic resonance will help us here. there, but this is still in the development phase. From the literature, we can see that there are several pros for surgery and section of the occult minimally tethered cord, and there are also cons as well. Many series with symptomatic children, the normal conus at RMI, in fact, to confirm the indication for surgery, but this comparing it with the clinical series in which patients have been, in fact, dealt with and surgerized when they have frank tethered cord system. The authors then also talk about neurological signs, which are the most frequent one, but also other disorders. We have also seen the fact that complete MRI should be done is sometimes not done, and in fact especially there is, however, the doubt that the phylum terminalis might be pathological, but also there are many arguments against. Jim Drake in particular talks of data on the fact that the definition of the syndrome is unclear, especially its natural history. He says the natural history is not clear with regard to tethered cord. He says 1/3 of his patients in fact don't have clinical progression, so the pathogenesis has only been shown in animal studies, and controversial neurological data are also scant. And in Surescum of 2000, in fact, had an interesting study. If you look at just neurological disturbances, in fact, 160,000 children on this basis would have been candidates for children, whereas a good percentage of these children, in fact, had spontaneous improvement of their neurological problems. So the key thing here is that we don't have prospective studies. In the number of cases that I have seen in the literature for surgery of tethered cord, the results are good, but only retrospective studies are there. We don't have, in fact, case control studies, however. Now, the only thing is Steinboxer, who says that in few children in a vast pediatric cohort, all of them here had tethered cord. 8 were treated surgically and 7 just medically followed up. The 8 treated had improvement, which was significant numerically, not statistically, because there are too few patients, but they improved compared to the non-treated patients. And the authors, however, also, of course, agree that with that small number, you can't draw conclusions. So let's see if there's any space for surgery of the phylum, as was mentioned by Mrs. Melorato. Also, when we have the presence of Chiari type 1 malformation, has come from this Congress, this is a pathology which has various facets. It's multifaceted, also in terms of its pathogenesis. We have all remembered and recalled that it's a mesodermal disorder, but it's not evident in the intrauterine period, and therefore there is something which triggers it. There are various disturbances and disorders, and where the pathology is confined or attributable to the development of the posterior cranial fossa, surgery, in fact, should be directed to this anatomical part. Obviously, one can probably have ectodermal origins like Chiari type 2 and 3, which of course is a different ballpark. So when is there an indication to treat malformation of Chiari type 1 with phylum section? Obviously, if the phylum is in fact symptomatic. This was a 3-year-old girl with a complex picture, a Kippel file, and other anomalies, an adipose fatty phylum, a tonsils that went below the foramen magnum, and torticollis, and imbalance. And she was very much resolved with dissection of the phylum. But cases like this, in fact, are fairly rare in the literature. I only found 16, and we can add the 6 presented by Mrs. Valentine and Sullivan, and the 3 that we operated on at our center. But even if not all are part of these criteria, however, we still only add up to 20. So is there a way that we can see some sort of common denominator? Now, the Cobb theory is fairly old. It says that the traction of the cord, in fact, causes the descent of the tonsils. Lichtenstein and Roth took this up, and they developed an idea that, in fact, there was a disproportionate growth of the spinal vertebra, and there was a compensatory growth of the cervical part. So on the basis of this, studies were carried out. Professor Di Rocco mentioned this on the 3rd day. There was an article which looked at clinical series, and Salvador operated on 20 adults. So 2 of them only had Clary malformation, and then the other ones had syringomyelia and scoliosis. And despite the fact that the conus was in the right position, the phylum radiologically was normal. In fact, it was sectioned. In all cases, the phylum was found to be non-elastic, even if the histological data is fairly scant. In fact, it didn't seem to be very abnormal. All patients had an acceptable follow-up clinically, even if radiologically there weren't many data, and the author here have a methodological bias due to the fact that some of the patients underwent extradural section and others intradural section of the phylum. I'd just like to mention 2 of the cadaver studies present in the literature. The phylum is very often has a fusion at the level of S1, S2 with the dura mater, and therefore that could be sufficient to solve the problem, but also sometimes it's seen as S1 in 15% of cases. It's above S1, and the range of movement in fact indicates this. So we think that endoscopic approach should be endodural. This should be followed. Now, there are various observations. Barry, for example, and associates have talked about the thoracolumbar nerve roots that show normal course. Goldstein and Keats showed in the animal that traction of the distal spinal cord is dissipated over 3-4 spinal sections. And this study of TAPS is very important. 12 cadavers with suboccipital cranectomy and attrition at C1. They have shown by pulling towards the bottom the phylum, there is no real change in the bulbocervical joint, even if the dural cul-de-sac was sectioned. And also showed that, in fact, the cerebellar tonsils were not affected. Studies in children, correlation was seen between Clary malformation and the position of the cord. Indeed, no correlation was found. Indeed, in some cases, the opposite was found. And in some cases, with meningocele, in fact, these are retrospective studies. these people with this and Chiari-1, I beg your pardon, didn't find any correlation, and the posterior fossa also was normal in size. One case here, by way of conclusion, I think that also in the case of Chiari malformation, Professor Milorat and Dr. Bolognesi can help us here. I think subgroups must be selected, and there are small subgroups of patients who can be candidates for section of the phylum, apart from the fact, provided that the fossa is normal and you don't have to have decompression, which we have seen is the treatment of choice and the key thing to do. So when we have Chiari malformation and a tethered cord, which is frank, there is an obvious indication. We could also, where the phylum and the conus are apparently normal, they could be nonetheless candidates for section of the phylum, even if there are a series of clinical indications that might make us suspect that there is a problem with the distal cord and hence with the conus. We apologize, but the speaker, if he goes at that speed, is well nigh impossible to translate, let alone understand. Thank you very much.